switching gear a little bit into real world practice, we know that CD19 CAR-T has now been FDA approved for close to 3 years now. And just looking at the patients now having access to this in the clinic across the US and data that's being presented, for example, with the CIBMTR database, we are recognizing that similar to bone marrow transplant, there are likely more patients that could qualify and be considered for CAR-T than the patients who are actually getting CAR-T. And now there can be many challenges for this access for patients. But one of the things we wanted to look at is outcome for patients who are able to receive CAR-T for the earliest FDA-approved indication compared to patients who may be getting to CAR-T after more lines of prior therapy. So the current FDA-approved indication for aggressive B-cell non-Hodgkin lymphoma is after 2 lines of systemic therapy. So this could be patients who had a second-line systemic chemotherapy but did not have adequate response to go on to stem cell transplant, or patients who did have sufficient response to second-line chemotherapy, had autologous stem cell transplant, and then had relapse. Those would be the earliest possible indication for FDA-approved CAR-T. So we look at our single-center experience for patients who received CAR-T in this setting versus patients who received CAR-T after more additional lines of salvage chemotherapy. And not surprisingly, the PFS and OS is better for patients who could receive CAR-T in the earlier line of setting. What prompted us to want to look at this also is that there are a small group of patients who, for various reasons, may have not had sufficient response to the second line of chemotherapy, but instead of being considered for CAR-T, went on to a third line of systemic therapy. And if they had a PR or greater response to that, they actually went on to get autologous stem cell transplant. So this would be transplant after 3 lines versus transplant after 2 lines of systemic therapy. And not surprisingly, when we look at those patient populations at our center, we're seeing that patients who are receiving stem cell transplant in second line versus third line are having a better PFS and OS in that setting. Now, a lot of this could be the biology of the lymphoma. Those that are more sensitive to treatment will likely have a better outcome compared to those who are refractory. So we also wanted to look at patients who receive CAR-T in second line versus the patients who receive stem cell transplant in third line to see if there's any difference in those outcomes. And we didn't see any difference in PFS or OS in those populations. Granted, this is a relatively smaller cohort now, and I think a larger population with more follow-up is needed to confirm this. So we cannot tell at this point if some of this may also be potential rescue effect from patients who receive CAR-T beyond third lines, or it's reflective, again, of the poor biologies of these more refractory lymphoma patients.